If you've been taking a blood pressure pill every single morning for the past year, Amlodipine, Losartan, or Lisinopril, how confident are you that you truly understand what that pill is doing inside your body right now? Not what the label says, not the single sentence your pharmacist printed on the bag. I mean, actually understand it, the way it works, the way it can quietly turn against you under the right conditions, and the warning signs that separate a minor inconvenience from a situation that demands urgent medical attention. Most people I talk to, educated people, careful people, people who read the news and manage their own finances, go quiet when I ask that question. And that pause tells me everything, because here's the thing, these are not weak medications. These are not vitamins. Amlodipine, Losartan, and Lisinopril are powerful drugs that change how your heart, your blood vessels, and your kidneys function every single day. And yet, millions of seniors take them on autopilot with very little understanding of what to watch for, what to avoid, or when something that feels completely ordinary is actually a signal your body is desperately trying to send. Today, I'm going to change that. My name is Dr. Caleb Mercer, and this channel exists for one reason, to give you the kind of clear, practical, honest health information that too often gets left out of a rushed 10-minute doctor's appointment. By the time this video ends, you're going to understand these 3 medications in a way that makes you safer, more confident, and far less likely to be caught off guard. And I want to start with something that happened to a gentleman named Harold, because his story sets up everything we need to talk about. Before we begin, take a second and tell me your name and where you're tuning in from. I read through the comments, and I genuinely want to know who I'm speaking to and supporting here. Harold was 73 years old, sharp, methodical, a former machinist who'd run his own shop for 30 years. He took his medications exactly as prescribed, never missed a single dose. His wife had set up a pill organizer labeled Monday through Sunday, and Harold treated it the way he used to treat his work orders. Precise on time, no exceptions. When his doctor added amlodipine to his regimen, Harold figured, one more blood pressure pill, same category, different name, no big deal. That single assumption almost cost him a year of his life. 3 months later, Harold's feet had changed so much that he couldn't squeeze into any of his regular shoes. His legs felt heavy and full by 4 o'clock every afternoon. He started cutting back on how much he walked because moving around only made it worse. He told his wife he thought his circulation was failing. He was frightened. He started Googling heart failure late at night. The real answer was something far simpler and far more manageable. But Harold didn't know it, because nobody had ever explained to him that amlodipine, Losartan, and Lisinopril are not the same kind of drug. They all lower blood pressure. That is where the similarity ends. Amlodipine is a calcium channel blocker. It works by relaxing the walls of your blood vessels, specifically the smooth muscle inside your arteries, so that blood flows with less resistance. Lisinopril is an ACE inhibitor. It blocks a specific enzyme in your body that tightens blood vessels, and by blocking it, the pressure comes down. Losartan is an ARB, an angiotensin receptor blocker. It works at a similar step in that same system, but through a slightly different door, and that difference matters far more than most people realize. 3 different mechanisms, 3 different side effect profiles, 3 different things to watch for. Once you understand that, you stop interpreting your body's signals through a one-size-fits-all lens. Harold's swelling was not heart failure. It was amlodipine doing exactly what amlodipine does in a significant percentage of the people who take it, relaxing the arteries more effectively than the veins, causing fluid to pool in the lower legs. Once that was identified and addressed, Harold was back in his walking shoes within a few weeks. The name on your bottle is not just a label. It is a category, and the category tells you the pattern. Let's go deeper. Let's talk about that swelling specifically, because it is one of the most widely misunderstood side effects in all of blood pressure medicine, and it affects a surprising number of people taking amlodipine. Here is what actually happens, explained simply. When amlodipine relaxes the small arteries in your legs, blood flows in more freely. But the veins, the vessels responsible for carrying that blood back up to your heart, don't relax in the same way. So you get an imbalance, more blood coming in than going out. Pressure builds up in those tiny vessels near your ankles and your feet, and eventually that pressure pushes fluid out of the vessels and into the surrounding tissue. The result, puffy ankles, socks that leave deep red marks, shoes that stop fitting, legs that feel heavy and full by late afternoon. This is not fluid retention from eating too much salt. This is not your kidneys failing. This is not heart failure starting. In most cases, it is a predictable physiological response to the way amlodipine works. Now here is the part that becomes genuinely dangerous. Not the swelling itself, but how people respond to it. Some people see the swelling and decide on their own to stop the medication without telling anyone, and their blood pressure quietly climbs back up while they feel like they made a sensible decision. Others keep taking the medication but start avoiding water because they believe they're retaining it, which is exactly the wrong direction, and dehydration on a calcium channel blocker carries its own risks. And some people, like Harold, simply endure it in silence for months, shrinking their world, reducing their activity, assuming the worst, losing quality of life that they never needed to lose. The right move, the move I want you to remember, is this. Leg swelling on amlodipine is a conversation your doctor needs to have with you, not because the drug is necessarily wrong for you, but because there may be adjustments, alternatives, or strategies that make it far more manageable. Elevating the legs, the timing of your dose, or in some cases reconsidering which medication fits your body best, those are all real options. But none of them happen if you suffer in silence. If you or someone you know is taking amlodipine, drop a comment below. Have you ever noticed that heavy, swollen feeling in your legs by the end of the day? You might be surprised how many people are quietly going through the exact same thing. Now let's talk about lisinopril and the most notorious side effect in the entire ACE inhibitor family, the cough. Not a wet cough, not a productive cough, but a dry, scratchy, relentless tickle in the back of your throat that tends to be worse at night and doesn't respond to cough drops, lozenges, antihistamines, or anything else in your medicine cabinet. Here is what makes this one so tricky. It often doesn't start right away. Some people develop it within the first week. Others take 3 or 4 months before the cough appears, and by that point, the connection to lisinopril never even crosses their mind. They've been on the medication for months without a problem, so they blame dust, allergies, a lingering cold, acid reflux, anything but the pill. I want you to meet Marion. Marion was 71, an avid gardener, and she assumed her cough was simply from spending so much time outdoors during pollen season. It was late spring when it started, which made the timing seem completely logical. She tried antihistamines. She bought an air purifier for her bedroom. She mentioned it to her primary doctor, who ordered a chest x-ray that came back perfectly clear. 6 months later, the cough was still there. Her sleep was disrupted almost every single night. She was exhausted, irritable, and beginning to believe that something serious was being missed. When she came to see me, one of the first questions I asked was, "When did you start lisinopril relative to when this cough appeared?" She went quiet, pulled out her phone, and started doing the math. She had started lisinopril 11 months before our visit. The cough had shown up about 4 months into treatment. She had never made the connection, not once. Once we identified the likely cause and worked with her primary doctor to switch her to Losartan, which targets a similar mechanism but does not cause this type of cough, the tickle in her throat was gone within 2 weeks. 11 months of disrupted sleep, gone in 2 weeks. The moment Son finally connected the dots. Now, and this is critically important, I need to draw a very clear line here, because there's a symptom in the ACE inhibitor category that is not a nuisance. It is a medical emergency. If you are on lisinopril and you develop swelling of your lips, your tongue, your face, or your throat, especially if swallowing or breathing becomes difficult, you do not wait. You do not call the office tomorrow. You do not take a Benadryl and see what happens. You call emergency services immediately. This is a condition called angioedema. It is rare, but it is real, and it can close off your airway faster than you would ever expect. A dry cough is a nuisance. Throat swelling is an emergency. The gap between those two things is enormous. Please burn it into your memory. And if nobody has ever broken down your blood pressure medication this clearly before, hit that subscribe button, because what's coming next in this video could be just as important for your safety, or the safety of someone you love. Now let's move to Losartan, and a danger that I find particularly striking, because it doesn't come from doing something wrong. It comes from people doing what they sincerely believe is the right thing. Losartan, like lisinopril, works on the renin-angiotensin system, your body's blood pressure regulation pathway. One of the effects of this class of medication is that it can raise the potassium levels in your blood. For most people, this stays within a safe range when it's monitored appropriately. But add certain common lifestyle choices on top of it, and the picture changes completely. Here is where it gets counterintuitive. Potassium doesn't just come from bananas or supplements. It's hiding in products that are actively marketed as the healthier choice, salt substitutes. Many of the popular low-sodium salt alternatives, the ones sitting right next to the regular table salt, often branded as heart-healthy, replace the sodium with potassium chloride. So a senior who has been told to cut back on salt buys a potassium-based substitute, uses it liberally on every single meal, and is now loading potassium into their system while taking a medication that already raises potassium levels. That combination can push potassium high enough to interfere with the electrical system of the heart. And here is what makes it so dangerous. High potassium doesn't always announce itself loudly. Sometimes it shows up quietly as unusual muscle weakness, persistent fatigue, a cramping sensation in the legs, tingling in the hands, or a fluttering, irregular heartbeat. And sometimes there are almost no symptoms at all, right up until there are very serious ones. I want you to think about someone in your life right now, maybe yourself, who has switched to a salt substitute in the last year or two. If that person takes Losartan or Lisinopril, this is a conversation that needs to happen with a doctor. Not because the medication is dangerous on its own, not because potassium-rich foods are evil, but because the combination, without awareness and monitoring, can create a slow-building problem that never needed to exist in the first place. Electrolyte powders, some meal replacement shakes, and certain over-the-counter sports recovery drinks also carry meaningful potassium loads. They're not prescription products. Nobody thinks to mention them. And that is exactly why they matter. There is one scenario that I don't believe gets nearly enough airtime in conversations about blood pressure medication and affects seniors more than any other group. What happens to these drugs when you get sick? Not a serious illness, not a hospitalization, just a bad stomach bug, a few days of vomiting, diarrhea that won't quit, a loss of appetite for a couple of days, or simply a hot stretch in summer with heavy sweating and not enough fluid intake. When you're dehydrated for any reason, the same dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated body can behave dramatically differently. Your blood pressure can fall too low. Your kidneys, which are already working harder because of the fluid loss, become far more vulnerable. Dizziness, weakness, faintness, or acute kidney strain can develop faster than most people expect. The medication didn't change. Your body's internal environment changed, and now the drug is operating in conditions it was never designed for. This is one of the most important practical things I can tell you today. Illness changes the rules, and if you don't have a plan for what to do when illness hits, whether to hold a dose, when to call the doctor, what symptoms should trigger a visit, you are leaving a significant gap in your own safety. That plan is something you should get from your prescribing doctor before you ever need it. If you don't have it, ask at your next appointment. What should I do with my blood pressure medication if I get a stomach virus or can't keep food and fluids down? It is one of the most important questions you can ask, and one of the least commonly asked. Here's a quick question for you. Has your doctor ever given you a sick day plan for your blood pressure medication? Drop a yes or a no in the comments, because I have a feeling most of you are going to answer the same way. Here's a scenario I want you to picture for a moment. You have a rough week. Your arthritis flares up. Your knees are aching, your back is stiff. So you head to the drugstore and pick up some ibuprofen, something you've used for years, perfectly ordinary, something off the shelf that anyone can buy. Now you're also taking Lisinopril or Losartan, and maybe you're on a diuretic as well, a water pill, for extra fluid management. That combination, when used regularly, can meaningfully reduce blood flow to your kidneys. And in the context of even mild dehydration, the risk of kidney injury rises substantially. This is not some rare hypothetical scenario. It is one of the most common, most preventable situations I see. And the reason it slips through is simple. Patients don't think of ibuprofen, naproxen, or similar over-the-counter anti-inflammatories as real medications in the same league as their prescriptions. They're just something from the drugstore. Something for the pain. But your kidneys do not distinguish between prescription and over-the-counter. They respond to chemistry. If you routinely use anti-inflammatory pain medications for arthritis, joint pain, or back pain, and you take any of these 3 blood pressure drugs, please have that conversation with your doctor. There are often safer alternatives: acetaminophen, topical treatments, physical therapy approaches, or other options that don't carry the same kidney risk. You don't have to just endure the pain, and you don't have to silently accept the risk. There is usually a better path. You just need someone to help you find it. I want to spend a moment on something that sounds small and absolutely is not. Dizziness. That brief, wobbly moment when you stand up from the couch or get out of bed in the morning. The world tilts for a second. You grab the doorframe, then it passes, and you go about your day thinking, just got up too fast. For many seniors on blood pressure medication, this is a regular experience, and it is almost universally underreported, because it seems too minor to bother mentioning. Here is what I need you to hear. In an older adult, a few seconds of dizziness is enough to cause a fall, and a fall is enough to cause a fracture. And a fracture, particularly a hip fracture, can derail an older adult's entire health trajectory in ways that take years to recover from, if they recover at all. This is not alarmism. This is physics and biology working together in a way that demands respect. The dizziness happens because your blood pressure medications are doing their job, lowering your blood pressure. And when you stand up quickly, your cardiovascular system hasn't had a moment to catch up. Your blood pressure briefly drops. Blood flow to your brain momentarily decreases, and you feel it as that lightheaded, tilting sensation. The fix is often simple. Rise slowly. Sit on the edge of the bed for a moment before you stand. Hold on to something stable as you get up. Give your body those few extra seconds to adjust to the change in position. But beyond the practical adjustment, dizziness that happens regularly, dizziness that doesn't improve after the first few weeks on a medication, or any episode of near fainting, those are signals that deserve a real conversation. The dose may need adjusting. The combination of medications may need a review. Something in your hydration habits may need to change. Silence on this one is not a small risk. Let me address something that creates an enormous amount of unnecessary anxiety, and occasionally some dangerous impulsive decisions for people managing their blood pressure at home. Your blood pressure is not a fixed number. It moves constantly, throughout every hour of every day, in response to dozens of variables: how well you slept, whether you had caffeine, whether you're in pain, whether you're anxious about the reading itself, whether you just walked in from outside, whether you spoke loudly right before you sat down. A single high reading on a random Tuesday morning after a poor night's sleep does not mean your medication is failing. A single low reading after you've been dehydrated on a hot day does not mean your medication is too strong. What matters is the pattern over time, measured consistently, same arm, same time of day, after 5 minutes of quiet rest without rushing or talking. When people monitor inconsistently and react emotionally to individual readings, the decisions that follow are almost never good ones. Extra doses taken out of fear. Skip doses because one reading happened to look good. Frantic calls to the doctor about a number that, in context, was completely unremarkable. Monitor with a method. Track it over time. Bring the log to your appointment. Let patterns, not panic, guide the conversation. That one simple shift in approach reduces anxiety, improves your decisions, and gives your doctor far more useful information than a single alarming screenshot from your home monitor. And if you've made it this far and you're getting value from this, type the number 9 in the comments. It's a simple way to let me know you're here and following along. These medications work through steady, consistent presence in your system, not through spikes and gaps, not through extra doses when you were worried, not through skip doses when you feel fine. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not designed to be taken reactively, the way you'd take a pain reliever after a headache appears. They are designed to create a stable chemical environment inside your cardiovascular system, sustained over time. When that consistency gets disrupted by missed doses, double doses, or erratic timing, your blood pressure can spike or dip in ways that feel like the medication isn't working, when in reality the problem is the pattern of use. If you miss a dose, the general guidance for most blood pressure medications is to take it when you remember, unless it's close to the time of your next scheduled dose. In that case, you skip it and continue normally. Do not take 2 doses to make up for the one you missed. But rather than relying on general guidance, ask your specific prescriber for specific instructions about what to do if you miss a dose of your particular medication. Write it down. Put it in your phone. Keep it with your pill organizer. Because in the moment when you realize you forgot, you do not want to be standing there guessing. I want to end with what I believe is the single most important point of this entire conversation, and it's one that almost always goes unsaid. The best blood pressure medication is not the one that produces the most impressive number on paper. It is the one you can take safely, consistently, and comfortably within the full reality of your health, your habits, your other medications, and your daily life. A medication that works beautifully on a clinical chart but causes you to lose sleep every night, swell so badly you stop walking, or feel so dizzy you're afraid to stand up, that is not a successful medication for you. Side effects are not a character flaw. They are not you being too sensitive. They are information. They are your body communicating in the only language it has, symptoms. And those symptoms deserve to be heard, evaluated, and responded to thoughtfully. Too many seniors endure side effects in silence because they assume, well, I need this medication, so I just have to live with it. That assumption is not medically sound. There are almost always options, dose adjustments, timing changes, alternative medications in a different class, combination strategies. But those options only appear when you speak up. Silence is not compliance. Suffering quietly through a side effect that makes you dread taking your medication every morning is not dedication. It is a setup for the day you stop taking it entirely without telling anyone, and that is the day your blood pressure climbs back up and everyone gets caught off guard. Your voice is part of the treatment plan. Use it. Let me leave you with the simple framework I want you to carry out of this video. If you take amlodipine, watch for leg and ankle swelling, especially by late afternoon, and report it rather than endure it. If you take lisinopril, watch for a persistent dry cough that doesn't respond to anything else, and know that throat or tongue swelling is a genuine emergency requiring immediate care. If you take Losartan, watch for the signs of high potassium, like muscle weakness or an irregular heartbeat. Review what's actually in your salt substitute, and have a sick day plan ready before you ever need it. And with all three, rise slowly to prevent falls, monitor your blood pressure with a consistent method, never combine them casually with anti-inflammatory pain relievers without guidance, and never stop them abruptly without talking to your doctor first. You took the time to watch this entire video. That tells me you take your health seriously. I hope this gave you something real, not fear, but clarity. Because clarity is what turns a prescription in your hand into a treatment plan you actually understand. If this helped you, share it with someone you love who's managing their blood pressure. Because this is the kind of information that quietly saves real people from real harm every single day. And right now, thousands of seniors are sitting in discomfort with a problem in their digestive system that they have no idea how to recognize or what to do about, and that's silence is exactly what makes it dangerous. Click the video on your screen right now, because it covers the silent digestive signals most seniors overlook until it's too late.